Very good evening, guys. So, welcome to the platform of DBMCI. I am Dr. Ramyasree. So, I'm going to discuss about high yield questions for INICET. So, am I audible and visible to all of you guys? Very good evening. So, I hope I'm audible and visible to all of you. So, right. So, we're going to start with the questions. I thought in this session of high yielding, I'll be mainly discussing the questions. So, I thought I'll start with questions which might be little difficult and where we might require to know how to solve it, and then I'll do some of the PYQs which have been asked in the recent time and which are important to us, right? So that will be the plan for this session. Okay, right. So let us start with the first question. So along with the question, I'll quickly recap the entire topic for you all. 32 weeks primigravida lady is admitted to the labor ward with irregular tightenings. She denies any history of bleeding for vagina or draining. She's an ex-smoker who recently quit smoking. See, whenever you get a very lengthy question, it's like mainly time taking, right? There are no significant medical or surgical problems. On examination, presentation is cephalic, cervix is posterior and closed. Urine analysis is negative. Woman is given the stat dose of a tocolytic, after which she develops severe headache, hypotension and flushing. To be frank, again, the entire question is the most important part is only this much. Correct? So, this is a 32-year-old primigravida who has come to you with threatened preterm labor. This is not preterm labor. This is threatened preterm labor because cervix is still closed. But as she had irregular contractions, they have given the tocolysis. They are asking us what in this question? They're asking which tocolysis is associated with headache, hypotension and flushing. Come on guys, can you quickly answer? So which tocolytic is associated with headache, hypotension and flushing? Is it ritodrin, isoxaprine, nifedipine or atosiban? So ritodrin and isoxaprine, these are beta adrenergics. Nifedipine is a calcium channel blocker. Atosiban is oxytocin antagonist. Yes. So the tocolytic which can cause headache, flushing and hypotension is nothing but the nifedipine. In spite of this causing headache, hypotension and flushing, the tocolytic of choice in pregnancy will be nifedipine itself. So nifedipine is the tocolytic of choice. Okay? Right. A quick few points which are important to us with respect to the preterm labor will write. So when do you call threatened preterm labor? So threatened preterm labor is when somebody has 8 contractions in 10 minutes, in 60 minutes, or the criteria for preterm labor is when somebody has 8 contractions in 60 minutes or 4 contractions in 20 minutes. Along with this, they should also have cervix more than 1 centimeter dilated and almost 80 to 90% effaced. So this is when they fulfill both contractions as well as the cervical changes. We call it as established preterm labor. Okay. How do you manage any case of preterm labor? So prevention is by progesterone. Progesterone can be given as prevention, but progesterone cannot be given as a treatment. Remember this point. Progesterone can be given as a prevention, but progesterone cannot be given as a treatment. So prevention is progesterone and cerclage. All patients you have to take high vaginal swab for group B streptococcus. Right? And if it is positive, you have to give injection benzyl penicillin at the onset of labor. At the onset of labor. Right? When does the lung maturity take place? 34 weeks. So if the patient is more than 34 weeks, you can deliver her because anyway lung maturity is there. But if you have not given steroids and she is not in active labor, can consider steroids. Can consider steroids up to 36 weeks. I'll share the PDF post class. Next, up to 34 weeks, you have to give tocolysis, steroids for the lung maturity, and magnesium sulfate for neuroprotection, and that is given between 28 to 32 weeks of gestation. Again, some single liners regarding the tocolysis, guys. What is the tocolytic of choice? Tocolytic of choice is nifedipine. What is the tocolytic which is useful in a heart disease patient? Atosiban. What is the tocolytic? Now I want you people to answer. What is the tocolytic which causes pulmonary edema? Both magnesium sulfate and beta adrenergics. But this is a rare side effect, but can be possible. For mother, highest side effects are with beta adrenergics. So it can lead to tremors, tachycardia, hyperglycemia and hypokalemia. Recently, they have asked you a question on the dose of steroids. Can you write the dose of steroids? So the dose of steroids is betamethasone 12 milligrams, 2 doses 24 hours apart, IM, or dexamethasone 6 milligrams, 4 doses 12 hours apart, IM. So either beta or dexa, any of this you can give, right? Okay, let's go to the next question now. 26-year-old woman in her second pregnancy has progressed normally in the first and second stages of labor. A forceps delivery is undertaken due to suboptimal CTG. There is difficulty in delivering the fetal shoulder. Help has been summoned. Suprapubic pressure and Mac Roberts have been unsuccessful. What is the appropriate next step? So this is about the shoulder dystocia. In recent time, you have got a lot of questions on shoulder dystocia. Especially, they want to know the sequence of the procedure what we do in the shoulder dystocia. So, can you think and tell me? So, very good, med student. So, can you think and tell me what should be the answer for this question? So, they have already tried suprapubic pressure and Mac Roberts. So, I'm definitely thinking they've already finished episiotomy. Because first what we do, call for help. Okay? After you call for help, see, she has done the help. Now, after that, we empty the bladder. We give the episiotomy. We bring the patient to the edge of the table. After that, we do the suprapubic pressure and Mac Roberts. After that, we do Wood's corkscrew. Excellent. Very good, Arshia, Jav and Saurabh. Very good. So what is the procedure here? Wood's corkscrew. So shoulder dystocia mein they mainly ask you the sequence of the procedure. So head to shoulder delivery time taking more than 1 minute is called as shoulder dystocia. So taking more than 1 minute is called shoulder dystocia. Just let us quickly speak about the sequence of the procedure. What we have in shoulder dystocia. So call for help. Bring the patient to the edge of the table. Empty bladder. Episiotomy. So I just pray like whatever we are discussing now should come in the exam, right? Almost 80% of them, right? So next, what we have, first maneuver. First maneuver is Mac Roberts. So what is Mac Roberts? Mac Roberts is hyperflexing both limbs on the abdomen and abducting. So hyperflexing both the limbs on the abdomen and abducting. So Mac Roberts, suprapubic pressure. After that, you rotate the baby, right? So you rotate the baby. So you rotating the baby is called as Loset's maneuver. Sorry, you rotating the baby is called as Wood's corkscrew maneuver. So all of you are absolutely correct. It is the Wood's corkscrew maneuver which we do after the suprapubic pressure. After Wood's corkscrew, what is the next maneuver we do? Any idea? So you trying to rotate the baby into the anteroposterior shoulder is called as Wood's corkscrew. So after Wood's corkscrew, what is the next maneuver we have? Posterior arm extraction. Posterior arm extraction. If all, and we also have shoulder shrug maneuver. Shoulder shrug maneuver. So that is you put your hand, shrug the baby shoulder near the chest and then pull it out. So shoulder shrug. If none of the above help, if all above fails, then we go for all fours or Gaskin's position. And repeat all. And repeat all. What are the three extreme? What are the three extreme methods? So the three extreme methods are you push the baby inside and go for cesarean. That's called Zanavelli. Or you can break the clavicle of the baby, fetal cledotomy, or you can break the pubic symphysis of the mother. Okay? Right? Let's go to the next question. See, again, labor is something you get lot of questions. So this one thing I want to make it easy for you through this during this session. So whenever you get a question on labor, please ask yourself which stage they belong to. So I want you to follow 3 steps whenever there is a question on labor. What is the stage? What is the diagnosis? Then the management. I want all of you to answer in the comment box based on this only for this question. A 32-year-old woman in her first pregnancy presents in spontaneous labor at 40 weeks and 4 days with rupture of membranes. On vaginal examination, the cervix is found to be 7 centimeters dilated. Meconium stain liquor is noted. Review of the admission CTG after 20 minutes is uninterpretable due to the area of loss of contact. What is the management you want to do? So what is the management you want to do for this patient? See, when there is meconium stain liquor, so meconium stain liquor suggests that we are dealing with a patient who is having fetal distress, and she's fetal distress with 7 centimeters. Yes, you might go for actually vacuum can be applied beyond 6 centimeters, but we don't know what is the station. When we don't know what is the station, what is the best thing to do? Better to go for cesarean section because she's still 7 centimeters. So that's why we are going to go for emergency LSCS. Which stage is this, guys? Very good. This is first stage, active phase, but this is associated with fetal distress. So as there is fetal distress, you have to go for LSCS. Yes, correct. So how did we know that there's fetal distress? Meconium stain liquor tells us that there is a fetal distress, right? Stage is first stage. This is first stage, active phase. First stage, active phase. So first stage is from the onset of true labor pains to full dilatation. Second stage is from full dilatation to expulsion of the fetus. Third stage is expulsion of the placenta. Right? And I want you people to tell me if this question would have been, let us take it as, she's 10 centimeters dilated, meconium stain liquor, head is -1. Then what would have been your answer? Same question. If patient is fully dilated, meconium stain liquor, head is at -1 station, what will be your answer? Again, ideally primary gravida mein you can wait for 1 hour. Yes, when she is fully dilated, she is second stage. Correct. This is normal. Normal duration is happening, right? But vertex is at -1. Right, none of you are answering correct actually. See, that's the problem with our these type of questions, right? Okay, so I would like to first tell you some points regarding this labor. Then I'll come back to this again. Let us see whether your answer will change. Let's recap about labor because that's very important. So first stage, you have latent phase, active phase. Latent phase is 0 to 5 centimeters, 0 to 4 centimeters according to WHO Labor Care Guide or recent WHO Intrapartum Care 2018. Active phases from 5 to 10 centimeters. So you have earlier WHO was modified WHO partogram, but recently we got another WHO that's called WHO Intrapartum Care or WHO Labor Care Guide. This was released in 2018. This was released in 2018 and now we are supposed to consider this one. Okay. So first stage mein you have latent phase and active phase. So on an average, primary takes on an average 10 to 12 hours. Multi takes around 6 to 8 hours. Prolonged latent phase are more than 20 hours or more than or equal to 14 hours. Prolonged latent phase mein treatment will be just wait and watch. Prolonged latent phase mein the treatment will be just wait and watch. Okay. Next, coming to the active phase. Again, primary and multi. What is normal? What is abnormal? So normal is the rate of dilatation and rate of descent. So rate of dilatation is 1.2 centimeter per hour. In primary, 1.5 centimeter per hour. Rate of descent 1 centimeter per hour, 2 centimeter per hour. According to WHO, everything should be minimum 1 centimeter per hour. If any of these goes late, the dilatations happens late. That is, if it is less than 1.2 centimeter per hour or less than 1.5 centimeter per hour, then we call it as prolonged or protracted active phase. Prolonged or protracted active phase. Okay. Arrest of descent is if there is no descent. If the arrest of descent is when descent is less than 1 centimeter per hour. Arrest of descent is when descent is less than 1 centimeter per hour. Okay. Right. Now next point I would like to put forward here is protracted or prolonged is taking more time. Active phase arrest. So what is active phase arrest? So active phase arrest is cervix more than 4 centimeters dilated, membrane absent, with adequate contraction, no dilatation, for 4 hours, and with inadequate contractions. You give oxytocin and no dilatation for 6 hours. No dilatation for 6 hours. So active phase arrest is cervix more than 4 centimeters dilated, membranes absent, with adequate contraction, no dilatation for 4 hours, with inadequate contraction, oxytocin given, and no dilatation for 6 hours. So this is the abnormalities of the first stage. Second stage is from full dilatation to expulsion of the fetus. So in second stage, again we have primary, multi, average. When do you call prolonged second stage? Second stage arrest. So you're going to remember it as 1, 2, 3. 1 hour, 2 hours, 3 hours. Multi, everything is half. 30 minutes, 1 hour, 2 hours. Normally we do Ridgen's maneuver to let the baby come out, right? But whenever it is prolonged second stage or second stage arrest, the management will depend on the station of the fetal head. This is one important point, guys. You have to remember this point. Whenever the head is above +2, you'll always go for cesarean. So see the station of the fetal head. So if head is above +2, then you'll go for LSCS. And if head is below +2, you'll go for instrumental delivery. Now, let us go back to the question which I told. The management is same for both prolonged second stage and second stage arrest. Let's go back to the question which I told. What did I tell you here? I told you that this is meconium stain, fully dilated. She's only there for 20 minutes. But as there is fetal distress, I would not like to wait on her. What should be the mode of delivery when station is head is at -1? So when station is -1, what should be the mode of delivery? Can you think and answer now again? Does your answer change after so much of me? As station is above +2, you have to go for. Still the answer will be LSCS. There is no change. Yes, excellent. Very good. So still the answer will be LSES. There won't be any change. So what is the simple thing point which you're going to remember? Whenever station is above +2, it's always LSES. Below +2 will be vaginal delivery. See, we would have all read these tables. But how to apply those tables back on a clinical scenario is what we have to learn. Right? Let's see one more question, clinical based. So they're not very difficult. It's just we have to break it down. That's all. 36-year-old woman in her second pregnancy had an uneventful first and second stage of labor. The placenta was delivered by continuous contraction. Shortly after the delivery of the placenta, she complained of severe abdominal pain and collapsed. On examination, pulse was noted to be 40, her blood pressure has 50/30. On abdominal examination, uterus was not palpable. What is the diagnosis? In recent times, you're getting a lot of questions on postpartum collapse. I want you to tell me what is the answer, then I'll tell you why did we come to this answer, not other answers. Okay, so I have you answering B, C. Yes. Okay, there is a confusion between B and C. Fine. Recent exams mein you got a question on amniotic fluid embolism, to be frank. Right? Now, all the options given here, first option which I'll rule out, which is not 100% answer, is abruption. Abruption is definitely ruled out, guys. Abruption will not cause postpartum, it is antepartum. Now, PPH can cause, amniotic fluid embolism can cause, uterine inversion can cause. For PPH, they'll have history of excess bleeding. What is a key point which is telling me that this is uterine inversion? So now I tell you the answer is uterine inversion. So what is the key point which is telling us that this is a uterine inversion? Inside on abdominal examination, uterus is not palpable is the key point which is telling that this is a uterine inversion. On abdominal examination, uterus not palpable is the key point which tells us this is a uterine inversion. Okay. See, most of the times we keep on doing the notes we keep on reading. But how to apply the notes back on the questions is important. So whenever you're preparing, only concentrating on revising the notes multiple times won't help you. 50%, okay, 60% revise notes, but 40% you have to solve the MCQs also. What will be the key point for if it would have been amniotic fluid embolism? What would be the key point in amniotic fluid embolism? Amniotic fluid embolism, you will see DIC, cyanosis. So that you don't have here. So in amniotic fluid embolism, you'll have DIC. Okay. So why there is severe shock here? Uterine inversion shock will be out of proportion to the bleeding. Why? Because there is both vagal shock and PPH. Now, in recent, yes, in amniotic fluid embolism, you will have sudden onset of breathlessness and DIC. Correct. In recent time, they have asked, what is the treatment of uterine inversion? Can you quickly tell me what should be the treatment of uterine inversion in this question? So what will be the treatment of uterine inversion? So uterine inversion, you have to immediately replace the uterus bag. That's called Johnson's method. After you replace the bag, you have to remove the placenta and give oxytocin. Okay? Yes. So manual reposition followed by placental removal followed by oxytocin. Most common cause of postpartum collapse is PPH, not uterine inversion. Next, 39-year-old woman in her first pregnancy is being induced for symphysis pubis dysfunction at 38 weeks. During the first stage of labor, she was noted to have uterine hyperstimulation, which was corrected by reducing the oxytocin infusion. She was delivered later by lower segment cesarean section for suboptimal CTG. 2 hours post-delivery, she complained of shortness of breath. On examination, she was noted to be cyanotic and her pulse was 100 beats per minute. Chest X-ray was performed that demonstrated a bilateral ground glass appearance with impaired coagulation profile. Can you answer what will be this one? For the previous question where it was uterine inversion, first you have to put it back manually and simultaneously resuscitation. Right? It is simultaneous resuscitation plus pushing the uterus back. Till uterus is like that, vagal stimulation will be there. No? So push the uterus back plus simultaneous resuscitation. Yes, this is amniotic fluid embolism because there is bilateral ground glass appearance and DIC. So that is breathlessness and DIC which we discussed just now. Correct. Right, let's go to the next question now. 27-year-old multiparous woman has had a rapid delivery soon after arriving in the delivery suite. After delivery, the placenta is noted to have heavy bleeding. Help has been summoned. What is the appropriate next step? A 27-year-old multiparous woman has a rapid delivery soon after arriving in the delivery suite. So there was a precipitate labor which led to PPH. So in PPH, she has first called for help. After call for help, what should be your next step? After call for help, immediately bimanual compression. Actually, indeed, you can actually write down the sequence and tell me what should come after the what. So after you call for help, the first thing what you have, as there is heavy bleeding, first thing what you have to do is give her IV access, intravenous access. Once she goes into shock, can you place the IV cannulas? See, in PPH, what do we do? First, preliminary methods. Then medical management. Yes, the answer should be B. The answer should be B, not D or C. That's what I'm trying to say. So there should be first preliminary method, then medical management, then tamponade methods, then it will be surgery. First preliminary, then medical, then tamponade, then surgery. Correct. Very good. Going with the flow. So you have to insert 2 wide bore IV cannulas, simultaneously draw blood for investigations and cross matching. Correct. 2 wide bore IV cannulas means which size? 16 gauge or 14 gauge. Right. Okay. Can you tell me? Actually, you should also examine the placenta, to be frank. So after IV access, examine the placenta. You can give 40 units of oxytocin. So if I have to tell the order, it should have been BCD. BCD. Okay. You should indeed know everything about the pph, the definitions, the numbers, what is the maximum amount of methogen. So oxytocin, good question. Why not A is a very good question. Actually, see, first we have to put two whiteboard IV cannulas because once she goes into shock, I cannot access it again. So that's why first put IV line and then you examine the placenta, no? To see if there are any retained bits inside. First deal with the shock. Oxytocin, you can start at 10 international units, maximum you will give 40 international units. What is the contraindication of oxytocin? Never give IV bolus. Never give IV bolus. What will happen if you give IV bolus? It will lead to arrhythmias and hypotension. Side effect of oxytocin is it will lead to water retention. Next we have methergin. Methergin is 0.2 milligrams, maximum 8 dose, maximum 5 doses, that is 1 milligram. What is a contraindication of methergin? What is a contraindication of methergin? Contraindication for methergin is I remember it with the mnemonic of do CPR. Do CPR. So after delivery of first twin, cardiac disease, P stands for pregnancy induced hypertension, RH negative pregnancy, right? And where is it? What is the side effect? Nausea, vomiting, hypertension, right? Carboprost is the most potent. It is PGF2 alpha, 250 micrograms. IM or intramyometrial. Maximum 8 doses, that is 2 milligrams. It causes diarrhea. So side effect, it causes diarrhea. Contraindication, asthmatics, and it also causes bronchoconstriction, no? So that's why it's contraindicated in asthmatics. Active cardiac, hepatic and renal disease. Okay. Next, last is misoprostol. Misoprostol, PGE1. 600, 800 micrograms. Maximum you can give 1000. Side effect, it can cause headache and fever. There are no contraindications for misoprostol postpartum. Right? Let's go to the next question now. Which type of episiotomy would be most appropriate to reduce the risk of severe perineal tear? Which type of episiotomy would be most appropriate to reduce the risk of severe perineal tear? Excellent, Levy. You AMTSL, you can either use methergin or you can either use misoprostol or you can use oxytocin. But what is not used is carboprost. Okay, right, good question. We will discuss all misoprostol doses. Correct, correct. So let's just do this question. I'll tell you all different areas. Mein the dose of misoprostol. So medial lateral episiotomy is best for to reduce the risk of perineal tear. So medial lateral episiotomy is placed at an angle of 60 degrees away from the midline. 60 degrees away from the midline. Okay. So now we'll just write about all the different where all how much dose of misoprostol we give. Okay. So this question and then I'll make you write. 32-year-old woman in her 4th pregnancy attends the delivery suit at 36 weeks with abdominal pain and bleeding. On physical examination, uterus is tense and tender to the palpation. Her BP is 160, pulse rate is 90, fetal heart rate is absent. This is confirmed by ultrasound. On vaginal examination, cervix is 4 centimeters dilated. Woman is contracting 3 in 10 minutes. Give prostaglandin E2, single dose of misoprostol, admission, IV access and coagulation screen, extra amniotic saline infusion. I'll be very happy if you tell me what should be the management for this patient and what is the diagnosis here. So see, this is the kind of questions which you might expect in INICET, guys. See, I've done plenty of videos where I've done like 2 hours revising the topic and all. So I thought like let me show you some type of questions which you might get in the exam and how will you interpret the answers for those questions. That's the main motto of this session. First you tell me what is the diagnosis here. And why is that diagnosis? Tell me both things. What do you think might be the diagnosis here? Excellent. Very good, Arshia and Monish. This is abruption. This is abruption, right? So what are the features which are pointing towards the abruption? Uterus is tense and tender. Excellent. And I assume this is a concealed abruption because patient only presented with abdominal pain and she didn't tell you about the bleeding for vagina. Right? Next, FHR is absent. FHR is absent. So this is a concealed abruption and fetal heart rate is absent. Now tell me what should be the management for this patient. So we have a grading for abruption. We have a grading for abruption. Stage 0, retro plus an retrospective diagnosis. Stage 1, uterus hypertonus tender. Stage 2, sorry, fetal distress to death. Fetal distress to death. Stage 3, maternal DIC, shock, death. Okay, right. Now, so she is in which stage? She is in which stage? Abruption is one of favorite topic of the examiner and I have seen so many times they are asking you so many questions on abruption, guys. I know you all know the management and everything, but still I would like to quickly recap about management once again. So you have to do simultaneous resuscitation. You have to do simultaneous resuscitation and delivery, correct? The mode of delivery is dependent on fetal status. If fetus is alive and if there is no fetal distress, you'll always try for vaginal delivery. You'll always try for vaginal delivery. If fetus is alive and there is fetal distress, then you go for LSCS. If fetus is dead, you have to first check for maternal DIC. First check for maternal DIC. If it is present, first correct the DIC. Absent, you go for vaginal delivery. I keep on shouting so many times in the classes ki please, 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 for abruption go for vaginal delivery unless until there is fetal distress. So definitely, as the baby is dead, you're all correct that you have to go for vaginal delivery. But the problem with INICET is you have to understand every option well. So this is one problem with INICET. You will understand the question. You will know the diagnosis. You will come to one management all very near to the management. Still you do wrong. So I see like most of you are writing 2 here. That is single dose misoprostol for vaginal delivery. Good. There is no option of LSCS actually. I should have kept one option of LSCS. But the answer what you have given here is wrong. Let us see. Let me tell you why again. So I have given you this table which I teach you regularly, correct? So now dead matlab you have gone to vaginal delivery. But what about this? In the option you have this no check maternal DIC. After you check for maternal DIC, then you have to go for vaginal delivery, no? So pehle check for maternal DIC. So how will you check for maternal DIC? Advice, IV access, coagulation screen. Good. Did you all like the twist? So the answer here is C. The answer is C. I hope you all understood why I've gone with the C. If I didn't have the option of C, then you would have gone for oxytocin or ARM, to be frank. Because cervix is already 4 centimeters dilated, misoprostol is not required. We give misoprostol when cervix is not open. 4 centimeters, you can either do ARM or you can either go for oxytocin, to be frank. Okay. Right. Now, some of you have asked me to tell me all the doses of misoprostol. No, that's actually ideal. Let us do one slide quickly about the doses of misoprostol in different conditions. Let us start with abortion. So misoprostol, first trimester abortion, we give 800 micrograms. 800 micrograms. You can either give PV or sublingual or buccal or oral. Second trimester abortion, it is 400 micrograms. Next, you can also add, guys, misoprostol is also used for induction of labor. Misoprostol is also used for induction of labor. Thank you, going with the flow. So misoprostol is also used for induction of labor. So for induction of labor, the dose of misoprostol is 25 micrograms per vaginal or 50 micrograms per oral. 25 micrograms per vaginal or 50 micrograms per oral. Next, it is also given for PPH. It's also given for PPH. In PPH, prophylactic dose in PPH prophylactic dose will be 600 micrograms, whereas therapeutic dose (800 to 1000 micrograms). That's all. These are the places where we give the misoprostol. I do agree there are different doses, but actually the dose of the misoprostol always reduces towards the term because number of receptors increase compared to first and second trimester. Okay. Right. So that's about the misoprostol. Misoprostol, when given for abortion, if still it continues, what is the syndrome associated with misoprostol? Can you tell me the congenital malformation associated with misoprostol? And antepartum, it is contraindicated in previous LSCS because it causes rupture of the uterus. Postpartum can be given. There are no contraindications. Only antepartum it is contraindicated. Mobius syndrome. Mobius syndrome. So the congenital malformation, very good Arshia, it is a Mobius syndrome. Next. So you have to answer this because just now I told this. Which one of the following method of induction of labor should not be used in patient with previous LSCS? Which one of the following methods of induction of labor should not be used in a patient with previous LSCS? Prostaglandin gel, prostaglandin tablet, stripping of membranes, oxytocin drip. Prostaglandin tablet, that is nothing but the misoprostol. So misoprostol is contraindicated in previous LSCS because it can lead to rupture of membranes. Yes. No, prostaglandin gel means dinoproston. Dinoproston. That is a cerviprime gel. This is not contraindicated. This is not contraindicated. Okay. So remember the drug of choice for ripening of the cervix is dinoproston. The drug of choice for ripening of the cervix is dinoproston, whereas the drug of choice for induction of labor is misoprostol. And for augmentation, it is oxytocin. ARM and oxytocin. Next question. 31-year-old para 2 lady attends the day assessment unit with a history of increased vaginal discharge at 32 weeks of gestation. She is not in labor. There is no evidence of premature rupture of membrane. A high vaginal swab shows bacterial vaginosis. See, one more which has been like commonly asked. See, whatever topics which I am discussing currently are some things which have been asked in the recent time. Abruption, uterine inversion, right? So these are certain topics which have been asked in recent time, labor based questions. That's the reason why I've kept. Another question which has been, another topic which is most of the times repeating is infections. So I am trying to ask in this question, what is the drug of choice of bacterial vaginosis in pregnancy? Very good, excellent. So bacterial vaginosis both in non-pregnant and pregnant state, it is metronidazole itself. Only in the first trimester we avoid overall metronidazole, but 32 weeks is third trimester, you can definitely give metronidazole. Yes. Who will quickly tell me what is the Amsel's criteria? What is Amsel's criteria? So first trimester में we can give metronidazole pessary. But second and third trimester we give oral metronidazole. So what is Amsel's criteria? So Amsel's criteria is pH more than 4.5, grayish white discharge, when you apply 10% KOH, there will be fishy odor, that you call it as whiff test positive. And clue cells more than 20%. That is bacteria attached to vaginal epithelial cells more than 20%. Okay. So pH more than 4.5, grayish white discharge, 10% KOH. When you apply, you will have fishy odor. That's called whiff test positive, and clue cells more than 20%. 30-year-old primary gravida attends the delivery suit at 39 weeks of gestation in established labor. On vaginal examination, she is 4 centimeters with foot presentation. What is the management for foot presentation? Emergency LSES, wait and watch, ARM, injection oxytocin. So foot presentation is a direct indication for LSES because it carries a high risk of cord prolapse. Okay. What are the other indications? What is the other thing where we go for cord prolapse? Even stargazing fetus. Even stargazing fetus. So both the stargazing fetus and footling presentation we go for emergency LSES. Next, I really wanted to convey this point of this question. A woman comes with obstructed labor and is grossly dehydrated. Investigation reveals fetal demise. What will be the management? You think and answer, then I'll help you out. A woman comes with obstructed labor and is grossly dehydrated. Investigation reveals fetal demise. What will be the management? So as she has already has dead baby, can we do like decapacitation or craniotomy or forceps extraction? Although the baby is dead, you have to still go for cesarean section. Why? Because obstructed labor is mainly due to cephalopelvic disproportion. It's mainly due to cephalopelvic disproportion. So obstructed labor is mainly due to cephalopelvic disproportion, because of which when baby is not coming out, it leads to a Bandel's ring. Yes, very good, Roy. Actually, from a very long time in modern obstetrics, we don't go for destructive operations. Baby is not able to come out, you go for cesarean section, right? Okay, what is a ring which develops in the obstructed labor? What is a ring which develops in the obstructed labor? So you have ring between thick upper segment and thin lower segment. So because of the CPD, obstructed labor is mainly seen due to cephalopelvic disproportion. As baby is not able to come out, uterus goes on contracting. This contracting uterus tries to pull the fetus down, right? So this will lead to one ring between the thick upper segment and thin lower segment. Yes, this is called Bandel's ring. In obstructed labor, if you don't do cesarean section and if you do delay in the management, it will lead to uterine rupture, and it can also lead to fistula, vesicovaginal fistula. Indeed, in India, the most common cause of vesicovaginal fistula is obstructed labor. Yes, it's also called as retraction, pathological retraction ring. Okay, let's go to the next question now. What is a maneuver which you are seeing in this picture? What is a maneuver which you are seeing in this picture? So most students get confused between Wood's corkscrew and Lowsets. Remember, for Wood's corkscrew, the buttocks will be inside, head will be outside. So this is buttocks outside, head inside. So there is an extended arm or nucleus displaced arm. So whenever you have a nucleus displacement of arm, it is, or extended arm, it is the Lowsets maneuver. Correct. How do I remember this? Low will set in with extended arm. Low sets with extended arm. Right. See, pathological retraction ring is mainly due to obstructed labor due to CPD. Whereas constriction ring or physiological constriction ring or Schroeder's ring is due to injudicious use of oxytocin, which leads to irregular contractions of the uterus leading to a ring. Okay. So that is due to injudicious use of oxytocin leading to irregular uterine contractions. Obstructed labor is associated with fetal distress. Constriction ring is not associated. Okay. So this is the Lowsets maneuver. Wood's corkscrew was the one which we have discussed in the starting of the session. No, Wood's corkscrew was discussed where? In Wood's corkscrew, when head is outside and shoulders are inside, you put two fingers on the anti aspect of the upper shoulder and two fingers on the posterior aspect of the lower shoulder. And then you rotate the baby in 180-degree direction into the anteroposterior diameter of the pelvis. Okay. Right. Where do we do Pinard's maneuver? Now let's complete all the maneuvers quickly. Where do we do Pinard's maneuver? Arrested lower limb. Ridgens is for the second stage of labor. Right. Wood's corkscrew was in shoulder dystocia. Starting only I told all the shoulder dystocia. I'll quickly show you all these images of different maneuvers and then we'll come back here once again. So I'll show you some important pictures now for another some time. So I would be very happy if you can tell me what are they instead of me speaking about them. So can you tell me what is this procedure? And at how many weeks do we do this? What is this procedure? At how many weeks do we do this? I think I'm not getting your messages. So this is a chorionic villus sampling. So you're pushing the needle into the placenta and you're taking the cells. So it's called chorionic villus sampling. This is mainly done between 11 to 13 weeks of gestation. So here you take the trophoblast for karyotyping. Abortion rate is 0.5 to 1%. It has a specific complication of oromandibular defect and limb reduction defect. But this is not the most common complication. That is the most specific complication. That is oromandibular defect and limb reduction defect. So whenever you take the needle into the placenta and prick the placenta and remove the trophoblast for karyotyping, it is called chorionic villus sampling. Chorionic villus sampling. Okay. Next. So this is the amniocentesis. When you're pushing the needle into the amniotic fluid and taking out the cells, it's called amniocentesis. Amniocentesis is done between 15 to 20 weeks of gestation. So I'm going to show you all important. This is the most safest because abortion rate is less than 0.5%. Here you take the fetal skin epithelial cells for karyotyping. Skin epithelial cells for karyotyping. Next, this is called chordocentesis. So in chordocentesis, you go prick at the level of the umbilical cord. So chordocentesis. Chordocentesis mein we take fetal WBCs. For karyotyping, and this is done between 18 to 20 weeks. 11 to 13, 15 to 20, 18 to 20. Remember. Right. What is the purple line? What is the green line? What is the blue line, guys? What is the purple line? What is the green line? What is the blue line? So in pelvis, I am somehow feeling they might ask you about the conjugates. So for the inlet, you have 3 conjugates where the posterior point is same, that is the sacral promontory, but anteriorly, depending on whether it is to the lower border of pubic symphysis or posterior surface or upper border, you have 3 conjugates. That is, you can remember it from below upwards, DOT. So dot may D stands for diagonal conjugate, O stands for obstetric conjugate, T stands for true conjugate or anatomical conjugate. So from the sacral promontory to the lower border of pubic symphysis, diagonal conjugate. From sacral promontory to posterior surface of pubic symphysis, diagonal conjugate. From sacral promontory to upper border of pubic symphysis, true conjugate or anatomical conjugate. The only measurable conjugate is diagonal conjugate, which is around 12 centimeters. Obstetric conjugate is 10.5, that is DC minus 1.5, whereas true conjugate or anatomical conjugate will be 11 centimeters. So how are we going to remember this? Dot, dot. This is how I remember. नीचे से ऊपर dot, नीचे से ऊपर dot. Yes, grips also can be asked as an image-based question. So the first grip, what you're seeing here, is called as fundal grip. Whenever the hands are towards the fundus, it's called fundal grip. Whenever the hands are towards the fundus, you call it as fundal grip, right? Similarly, if the hands are towards the lateral aspect of the uterus, it's called lateral grip or umbilical grip. Oh, there are another 2 grips which are missing here. Fundal grip tells you about what is present in the fundus, whether it's a head or whether it's a breech. Lateral grip, if you see multiple knob-like structure, it is the fetal limbs. If you feel there is a smooth curvy linear resistance, it is the back. This is the Ridgens. Yeah, there is one more grip missing. So when you put thumb on one side and 4 fingers on the other side, it's called as Pollock's grip or Leopold III maneuver. So Leopold IV maneuver is by seeing the patient's feet, your hands are converging or diverging to know whether there is descent of the fetal head and whether the head is engaged or not engaged. So once head goes inside, it is engaged, no? So it is telling you about the descent also. So whether head has descended into the pelvis or not. So this is Ridgens. This is Brandt-Andrew method. Where do we do this Brandt-Andrew method, guys? This Brandt-Andrew method is also called as control cord traction. Control cord traction. You do it in active management of third stage of labor. You do it in the active management of third stage of labor, right? ECV, the prerequisites for ECV has come as an exam question many times, guys. So the prerequisites for ECV are gestational age should be between 36 weeks to term. Patient should not be in labor. Patient should not be in labor. Very good. Control contraction of Brandt-Sandler method is done in active management of third stage of labor. It should be a singleton fetus. Liquor should be adequate. Membrane absent. So the prerequisites are gestational age should be between 36 weeks to term, singleton fetus, liquor should be adequate, membrane absent. Sorry, membrane should be present. Liquor should be adequate and membrane should be present. Okay. I think that's, yeah. Pelvis should be adequate. And there should be no obstetric indications for cesarean section. No obstetric indications for C-section. So when there is placenta previa or previous classical, there's no point in ECV. When there's placenta previa or previous classical, there's no point in ECV, right? Because anyway you're going to do cesarean section. Why do you want to rotate the baby up and down? This is called modified Prague maneuver for dorso-posterior breech. Modified Prague maneuver for dorso-posterior breech. So this is called Vigor-Martin. This is called Vigor-Martin. So in Vigor-Martin we do suprapubic, we give suprapubic pressure plus malar flexion. Plus malar flexion. So in Vigor-Martin we give suprapubic pressure plus malar flexion. This is also for the aftercoming head of breech. This is also for the aftercoming head of breech. This is called Mauritius Melly-Wheat. So in Mauritius Melly-Wheat you give suprapubic pressure, malar flexion, shoulder traction. 3 names, 3 hands. Suprapubic pressure, shoulder traction, malar flexion. Low sets for the extended arm or nuchal displacement of arm, where the arm is up. Arrested lower limb, pinnards. Pinnards. For aftercoming head of breech, you can also hold the baby at the ankle and pull it up vertically as an arc. This is called Bern-Marshall. This is called Bern-Marshall. Right? Yes. When you hold the baby's legs and pull it down, it's called internal podalic version. Internal podalic version is done only for the transverse lie second twin. Singleton may you will not do. Only for transverse lie second twin. So those were some important topics in OBS as well as important questions in OBS and important images in OBS. Okay. And apart from this, I want all of you to definitely go through hypertensive disorders also. You tend to get a lot of questions from there. At least one question. Right. So now we'll go for the gynec. What is the use of the instrument given below? PDF I'll send you post class. What is the use of the instrument given below? So whenever you have the triangular, it is nothing but the triangle conical, it is nothing but the Leach-Wilkinson cannula. Very good, Saurabh. This is Leach-Wilkinson cannula, which we mainly use for hysterosalpingography. So it's the Leach-Wilkinson cannula. Okay. A patient is scheduled to undergo a full laparoscopic hysterectomy and wishes to understand the drawbacks associated with this technique. So now what I'm discussing are the PYQs itself, guys. So whatever the weird like clinical based questions which I wanted to show you, like which pattern can come, first I tried to put forward. Now I'm showing you like next another 40 minutes. 40 minutes may I will just discuss about the PYQs itself. PDF I'll be sending it in the DBMCI regular batch telegram. DBMCI regular batch telegram. Okay. So actually laparoscopic is always better than abdominal hysterectomy because laparoscopy will help in faster recovery. Laparoscopy may you'll have decreased pain, decreased bleeding, but the only drawback of laparoscopy is we don't know how much is the extent of the burns. So when you are burning something, you don't know how much deep that burn is going. That's the only problem. So what are the disadvantages of laparoscopic surgery compared to open surgery? Not knowing the extent of the thermal burns. Prolonged recovery time? No, it takes less recovery time. Increased bleeding? No, it takes less bleeding. Increased pain? It takes there's less pain and it heals faster. Okay. Again, the management of ectopic pregnancy is something which is important, guys. A female presents to you with 6 weeks of amenorrhea, complaining of bleeding for vaginum and slight abdominal pain. The urine pregnancy test is positive and HCG level is 2800 international units per liter. A mass is seen on the left adnexal mass, left adnexa measuring 3 into 2.5. She is hemodynamically stable. What will be your management? This is also a PYQ. So quickly I'll tell you what are the 3 modalities of management and everything. Correct. You're all answering correct. So now what I've started is PYQ. So I'm expecting you people to answer correct. But starting me what I did was if somebody missed the starting session, I would request you to watch the starting session also because we discussed some nice fun questions. Very good. Excellent. All of you are correct. Single dose methotrexate. Where do we give serial methotrexate and leucovorin rescue? Where do we give serial methotrexate and leucovorin rescue? Choriocarcinoma. So why am I going for single dose methotrexate injection is because the sac size is less than 3.5, FHR is absent, patient is hemodynamically stable, and beta HCG is less than 5000. Beta HCG less than 5000, you can always do medical management. Patient should be ready for follow-up. Okay. So sac size less than 3.5 centimeters, FHR absent, beta HCG less than 5000, you will do medical management. If it would have been more than 3.5 or FHR present or beta HCG more than 5000, then you will go for surgical management. Which of the following is the most common organism associated with PID? Neisseria, Gardnerella, bacteroids, chlamydia. So the most common organism causing PID is chlamydia more than gonococci. Chlamydia more than gonococci. Okay. Even for cervicitis also it is chlamydia more than gonococci. Chlamydia, the treatment is azithromycin 1 gram stat. No. It's chlamydia which is most common. Most common cause of PID is chlamydia trachomatis D2K. Chlamydia trachomatis D2K. So we give azithromycin 1 gram stat or you can give tab doxycycline. 100 milligrams BD for 10 days. Gonococci, the drug of choice is injection ceftriaxone 250 milligrams QID. Sorry, IM injections. Yeah. So what is the most common organism associated with Bartholin cyst? Bartholin cyst, E. coli more than gonococci. Most common organism causing PID in virgin females. See this chlamydia, Neisseria, all these are STDs. Sperm acts as a carrier. So most common organism causing PID in virgin females is tuberculosis. Most common organism associated with IUCD users. What is the most common organism associated with IUCD users? Actinomyces israeli. Actinomyces israeli. Okay. What is the normal uterocervical length? What is the normal uterocervical length? So normally, how do we measure the uterocervical length? Uterocervical length is measured with uterine sound. So it is a olive tipped uterine sound. Okay. So this uterine sound, uterus is normally 10 centimeters, 8 to 10 centimeters, and cervix is around 3 to 4 centimeters. So let's consider that entire uterus is around 13 centimeters. So 13 centimeters is how many inches? 5.5 inches. So you can go with the option of B, 5 inches. Yes. Uterine malformations is also something which they'll ask you many times. Uterine malformation is also something which they'll ask you many times. 30-year-old female married for the past 5 years presents with the complaints of inability to conceive despite regular intercourse. Physical examination is unremarkable. Semen analysis of the husband shows no abnormalities. HSG reveals the following picture. The anomaly shown in the image below falls under which category of American Fertility Society classification? First, I want you to tell me what is this picture. Then I'll help you out. I'll give you a nice mnemonic to remember the Fertility Society classification. What is this? So this is the unicornuate uterus. Very good. This is unicornuate uterus. Right? Correct. That is the unicornuate uterus. So you can remember the classification of the uterine anomalies with the mnemonic of mud be sad. Mud be sad. So mud be sad में first two are formation defects. First one में uterine duct has not formed at all. It's MRKH or complete Mullerian agenesis. Or complete Mullerian agenesis. Next you have unicornuate uterus. So uniconnovate uterus mein one duct is developed and another duct is not developed. So they have one horn with single fallopian tube. One horn with single fallopian tube. Okay. So that's the uniconnovate uterus. D is didelphys. So didelphys mein both horns have developed but they have not fused. So there will be two uterus, two cervix and two vagina. So didelphys and bicornovate. These are fusion defects. Then we have septate and arcuate. This is septal resolution defect. Last is in utero exposure to diethyl stilbestrol. So easy, no? You can remember it as mud be sad. Bacha fell in the mud and he became sad. Mud be sad. Bacha fell in the mud and he became sad. So MRKH, uniconnovate uterus, didelphys, biconnovate, septate, arcuate, in utero exposure to diethyl stilbestrol. Right? Yes. Uniconnovate is the most common associated with renal anomaly and this will be a banana shaped uterus. Banana shaped uterus. What is the investigation of choice for detecting the uterine anomalies? So investigation of choice is 3D USG or MRI, whereas gold standard is hysteroscopy and laparoscopy. That is by hysteroscopy seeing from inside and laparoscopy seeing from outside. Actually, as per the MCQs, HSG has no role. As per the MCQs, HSG has no role. But so many times they have given the HSG pictures for the exam. The indication why we are going to treat this is mainly when they have recurrent abortions. Is when they have recurrent abortion. Treatment is if it is didelphys or if it is bicornovate, you will go for metroplasty. You remove the medial half of the uterus and make it as one. Metroplasty. Strassman's metroplasty. But if it is septate uterus, you're going to remove the septum from down. That is called hysteroscopic septal resection. Hysteroscopic septal resection. Okay? Right. So this also is your PYQ. What is the type of hymen which you are seeing here? So this has a septum in between. So this is called as septate hymen. Septate hymen. You also have annular, semilunar and imperforate. So here what we are seeing is septate hymen. Yes. So urogynecology mein vesicovaginal fistula is something so many times they tend to ask you. So what would be your recommendation when discharging a patient who has undergone a vesicovaginal fistula repair? So again, I'm going to simplify the VVF. So VVF, most common cause is obstructed labor, in India. In India, most common cause is obstructed labor, right? So they'll mainly present you with continuous passage of urine from vagina plus continuous passage of urine from vagina plus voluntary. There's no voluntary micturition. There is no voluntary micturition, right? Whereas uretrovaginal, they'll have voluntary micturition also. Okay. Next. Investigation of choice is cystoscopy. When diagnosed within 24 hours. Diagnosis within 24 hours, repair immediately. After 24 hours, you have to repair after 6 weeks. So when diagnosis within 24 hours, you repair immediately. If you have diagnosed it after 24 hours, repair after 6 weeks. Right, the surgery what we do is called Lasco's technique or 3-layer technique. Lasco or 3-layer technique. And after you have done Lasco technique or 3-layer technique, post repair you have to remember 1, 2, 3. Post repair 2 weeks catheterization, 1 year no pregnancy, and 3 months avoid intercourse. Okay, so the same thing has been asked here. What would you do? What would be your recommendation when discharging a patient who has undergone vesicovaginal fistula repair? Sexual abstinence for 3 months and avoid pregnancy for a year. So A will be the correct answer, right? So now I'm going to take your queries and then I'll end for today. So Shiv Kumar, endometrial cancer, no need of going through the staging and management because it's very there's a new staging which is like too big and not at all you cannot remember it. Ovarian cancer, no need of going through the staging, but management, yeah, I think ovarian cancer and cervical cancer staging you should know. Vulval cancer also management better to know because they have asked in the recent times. I've actually made some short videos on how to remember the ovarian cancer staging, how to remember the cervical cancer staging. You just have to in Dr. Bhatia Medical Coaching, our own YouTube channel itself. You just type Dr. Ramyasree mnemonic for cervical cancer and mnemonic for ovarian cancer. You'll get it. Okay. So before I end, you can ask me any queries if you want. So that you can definitely ask me any queries. Okay, so on the whole, what are the important topics which you should read before you go for your exam? I'll tell you. So in OBS, go through preeclampsia, aneuploidy screening, labor, antepartum hemorrhage, abruption and placenta previa, miscarriage, molar, ectopic. These are some common favorite topics, guys. Like extreme favorite topics I'm telling you now. Okay. Right. Now coming to the gynec. Gynec में what is important is amenorrheas. Actually very important is amenorrhea. Amenorrhea, cervical cancer, infections. These three are the golden topics where you definitely tend to get one question. So infection mein you should know ulcers, you should know vaginitis, you should know cervicitis, we should know these ulcers and vaginitis and cervicitis. Okay, so these you should be knowing. Okay, right. Now cancers may cervical cancer do everything. Yes, ovarian cancer may they'll mainly ask you tumor markers and HPE, whereas endometrial cancer they'll mainly ask you risk factors and what is the cutoff for the endometrial thickness on TVS. All those are small things which they ask. Okay, we'll quickly recap the tumor markers and histopathological examination finding in the ovarian cancers. So what is the most common ovarian cancers are epithelial. In epithelial, most common is serous. Serous में tumor marker is CA 125. Whereas histopathological examination, you'll have samoma bodies. Mucinous carcinoembryonic antigen. This can present you with pseudomyxoma peritoniae. Mucinous is the largest growing ovarian tumor, right? Then you have Brenner's. So Brenner's, you don't have tumor marker, but histopathological finding, it will be vaulted cell rest. Serous, mucinous, clear cell, endodermal sinus tumor, and Brenner's, right? Endometrioid. So clear cell, you'll have coming to the germ cell tumors, most common is dermoid. So in dermoid, very, very classical is all three germ cell layers. Embryonal carcinoma, HCG and alpha fetoprotein, and you'll see embryoid bodies. Yolk sac tumor, what is the tumor marker in yolk sac tumor? See, yolk sac produces AFP, no? So yolk sac tumor AFP, and in yolk sac tumor you'll have Schiller dual bodies. Schiller dual bodies. Next we have choriocarcinoma, HCG. Where do we see glial tissues? Glial tissue in immature teratoma. Glial tissue in immature teratoma. Right? Next. LDH and alkaline phosphatase. So LDH and alkaline phosphatase we mainly see in the dysgerminoma. So you have lymphocytic infiltration, plus fibrous tissue. Granulosa cell tumor. Inhibin, Karl-Exner bodies. Karl-Exner bodies. Yes. Coffee bean cells are seen in clear cell. Okay. So those are some of the important, most importantly, you have to be very positive. Just give your best shot. Just be cool, calm. Whatever you have learned, trust it and go forward and give the exam. So you're going to do wonderful. Thank you so much, guys. All the best. Keep studying, keep learning. Any other doubts you can put forward. I'll help you out. Before we end the session, any other doubts you can tell me. I'll help you out. So, good night, guys. Sweet dreams. All the best. Keep studying. Thank you so much. Thank you so much for listening to the entire session. Thank you so much.